Hello and good afternoon. It is good afternoon. I was thinking, was it morning or afternoon? So I'm very pleased to offer a really warm welcome to Miss Georgina Fraser. You may well have tuned in. Was it last month we did our last webinar, wasn't it? Which was really, I know it's been really popular because we've had so many people download it to view. So thank you very much for that. And sort of progressing on from what we were discussing last time, we're going to look at pelvic floor, which I just think people don't talk about it enough, but it is just one of the most important things. But before we dive into that, Georgie, what would be nice is just to reintroduce you again to people who might have not seen our first chat, and to say that Georgina is Miss Georgina Fraser, and you are a consultant obstetrician and gynecologist. And is that a normal combination of roles?
Yes, absolutely. So yeah, you dual train and then you specialist interest in something, and mine is basically the correlation between obstetrics, pelvic floor, and then from that it came on to what happens to the pelvic floor later on, and menopause stuff. So yeah, mostly to do with perineal problems and the pelvic floor and how that relates to prolapse and incontinence.
So I was just going to dive straight in there to a question, which is really hard. It's really hard not to do. Do you find that most people's problem with their pelvic floor, is it from having children, or is it from other issues?
So a lot of the problems, so we do see women who have no problem, who have not had children with problems with their pelvic floor, but you usually find it's later on in life. You rarely see a 20-year-old with pelvic floor problems. It tends to be after the menopause, where our estrogen levels go, and we generally all lose muscle mass. I think that starts from 30, especially as women. Yes, there is an element it's related to childbirth, especially if bigger babies, malposition, and the use of forceps is related to problems later on with the pelvic floor. And also how many babies you had. You're more likely, if someone's carried 6 babies, then they're more likely to have problems regarding pelvic floor dysfunction than someone who's had no children. Although, a cesarean section doesn't protect you completely, and we know that.
Yeah. So now that I've dived straight in, we'll take a step back. Perhaps it would be a good idea to kind of explain properly to people when we're talking about pelvic floor, what exactly we mean by a pelvic floor.
So I'm not a physio, but the pelvic floor musculature is basically a hammock. So if you think of a hammock holding everything in, then this hammock holds all your intra-abdominal organs in, and it wraps around this very complicated, it's called the levator ani, and it's a complicated mixture of different muscles which go around the vagina. So you've got your vulva, and then you've got your vagina. They wrap around the vagina, then they wrap around the urethra, which is the hole where your urine comes out of. So where it goes from your bladder into your urethra, and then you get your outlet. So there's a little, sort of almost like a circular muscle around there, and also around your anus. So if you have weakness of those muscles, which hold everything, you can see my hands, but they almost hold everything up. You weak them, and you say you cough or you jump, and you put pressure on the top, so on that pelvic floor, then that sphincter, that muscle, isn't able to hold it, so you can leak urine. You go into your middle compartment, that's your vagina, and you jump or just there, and you can get the walls of your vagina can come down, and that's prolapse, and that can also, it keeps up your uterus as well, so you can get uterine prolapse. And then the one that nobody talks about is fecal incontinence, because these muscles go around your sphincter as well of your anus, and so if they're weak, as you get older, if they weaken and we don't strengthen them, then you can get a little bit of fecal incontinence or flatus incontinence, wind, which is the taboo, but it's really common. It's really common. Nobody talks about it because I find it so embarrassing. And actually, it's quite easily fixed with.
Oh, really?
It's all about pelvic floor exercises initially.
And I suppose we always talk about pelvic floor with women, but men obviously have a pelvic floor.
They do, and if I might blush, but apparently men should. If you speak to I mean, I don't do any men, so I'm completely female orientated. But if you speak to the physiotherapists, they'll say men have a pelvic floor too, and it can improve their sexual length, how long they can hold an erection, apparently, and improve.
Oh, really?
Yeah, it's good knowledge.
I expect a lot of them would like to know about that.
I like divulging that information because it's always about the women, but I mean, we're not. That's all I can say in that area.
Yeah, but it is important if you're talking about fetal incontinence, because that is such a debilitating condition or symptom to have on anybody's lifestyle, isn't it?
Absolutely, it's one of the worst, and it's you'll hear of very sad occasions when, especially in the line of work I do, and occasionally you will hear of women being fecal incontinent after childbirth. Oh, it's just awful. They can't go out, and their lives, especially with a young baby. And again, it happens later on. And the first thing you say is go and see a pelvic floor physio because they can strengthen that and teach you how to strengthen. And I think it's sometimes the engagement between the brain and the pelvic floor just isn't there. I remember when I had my babies, I'd be lying doing Pilates and they'd be like, lift that. Didn't do it because it was just, I wasn't strong. And actually, I think it takes practice. It's like anything. If you want a six-pack of your tummy, you've got to do sit-ups or you've got to engage the pelvic floor. And the physios are brilliant at that.
And so there's sort of three layers. There's fetal, there's the womb.
Yeah.
And then there's the urethra side. So there's sort of three, is that right? Sort of three main things. So if we just go while we're talking about fetal, let's just sort of talk about that. You're saying that if you or someone suffers from it, there are absolutely things that could.
Yeah, I mean, it's not easy, and surgically wise, no, it's not great. But actually, if it's why the pelvic floor is so important. I mean, it's easier to treat middle compartment, which is vaginal and uterine urinary incontinence. It's more difficult to treat fecal incontinence. It's not actually something that goes to the general surgeons, but there is lots of evidence that actually improving that pelvic floor and strengthening it can help.
Right. Okay. So then moving on downwards or across, I'm not quite sure which way it might.
Why don't we go to urethral? Why don't we go to it's not urethral, urinary incontinence.
Yeah.
Stress incontinence.
Okay, and so I mean, obviously, lots of ladies and men suffer from this issues, which can either be caused, obviously, from giving childbirth or from a neurological condition.
Yeah, so urinary incontinence is quite complex. It's not just childbirth. There's a lot of other things. It's about weakening the pelvic floor, and there's a lot of other things that can weaken the pelvic floor. Not doing the pelvic floor exercises, too much body weight, obesity, that's very common. It's anything that pushes down. Constipation, if you're constantly straining on that pelvic floor, it's going to be weaker. Heavy weights. So I often find women, sometimes they'll be doing too heavy weights and not doing it properly. So they're wondering why they're leaking while they're lifting huge dead weights. Trampolining, anything that goes on that pelvic floor. Chronic cough. So if you're coughing all the time, something's got to give, and that's what happens. So, and often you'll see, interestingly, I've got this photo, I don't have this picture, but I've got it of a weightlifter in the Olympics, and she's lifting these massive weights. I mean, it's so impressive, but there is a puddle of urine on the bottom. And it's just because this is too much for her pelvic floor to manage. Something's got to give, and so the urine leaks. So yes, your first thing you do is supervise pelvic floor exercises and try and stop that. The other form of urinary incontinence you're talking about is what we call detrusor overactivity or overactive bladder symptoms. And hands up, I'll have a cup of coffee. If I've had 2 cups of caffeinated coffee, I have urgency and you run. And that is what we call overactive bladder, wet or dry. And that's that feeling of the bladder contracting and you can't hold it. And that's often gets worse with age because of lack of estrogen. So vaginal estrogen, always use vaginal estrogen. It's brilliant stuff. And then there are medications for that. And the last line is Botox. So that's not weakness of the pelvic floor. That's contractual. You know that feeling where you put your keys in the door and you're like, people get that all the time. And that's just about increasing your drinking, stopping caffeine, and then there are other things we can do.
So caffeine is a stimulant.
The bladder.
Okay, and would alcohol be classed as a stimulant as well?
And some people, citrus, fizzy drinks.
Oh, right.
Chocolate. Some people. Yeah, I know, that's quite. It's anything, your bladder should have clear fluid in it. And so people, what happens is your vicious circle is you leak, so you stop drinking.
Yeah.
So you drink maybe 2 coffees a day. Oh, I don't want to leak, so you don't drink enough. So all you get is concentrated fluid in your bladder, so that then your bladder goes, oh, this is horrible, and irritates it, and that's when you get the contractility, the overactive.
And things that one can do for, I mean, there is medication for overactive bladder, isn't there?
Yeah. So first thing is bladder retraining. It's a muscle that remembers things. So you say you're not going every 10 minutes. You kind of hold out. Because you should be, weighing about 300, 400. The bladder can hold up to 500. So you do bigger volumes, drink lots of clear fluid, and about 2 litres a day, avoid caffeine, and then you go down the medicine lines. And we've got 2 forms of medicines which stop that contractility of the bladder. And then last line is Botox.
Right. And the Botox, is that, do they inject Botox?
Into the bladder wall. So just like you'd have Botox in your face, you can put it in the bladder wall just to stop the contracting. But that's a last line.
Right. And does that contracting, is it something that sort of creeps up on somebody having overactive bladder? Or is it just suddenly you get it?
It does tend to creep up. And it's the sort of things which really affects the elderly. So they have it, the elderly population, they feel that they need to go to the loo all the time and they'll be passing very small amounts of urine. And it's that going to the loo all the time, being up at night. So naturally people as you get older, people get up at night. But people are up 5-6 times at night. So they've got daytime tiredness and they become more unhealthy, etc. So it's something that if we can treat is really good.
I remember speaking to somebody, and I can't, because I'm useless at names, as we know, something called, begins with N. It's one of those conditions, I think you create as much urine as you do during the day as you do at night time. Yeah. And you suddenly realise how everything connects, because the older you get, you still have to go to the loo. You then become more wobbly, and that's when they find most people have falls at night, and then people are going to the NHS. And it's just amazing how everything just all kind of unfortunately connects.
Yeah, and that's why it's all about preventive. So I think, there's so much more about preventative. Using vaginal estrogen early doors when you get to the menopause, doing your pelvic floor, making sure you don't drink. There's a culture, isn't there, that we have caffeinated. It's England. We're always drinking tea, caffeinated tea. Oh, just make me a cup of tea, and it's done in kindness, but actually, it's that probably stimulates the bladder and makes them worse. Where actually they should be having a glass of water. There again, you can't take away all pleasure. So,
and then with the vaginal stuff, is that a prescription medicine, or is that something that you can buy over the counter?
It is prescription. So there's vaginal estrogen. It is prescription, but it should, your GP, if you've got dryness within the vagina, then it should be fairly. It's also about maintaining sexual activity if that's what you choose, and it keeps the tissues in good stead, but also it does affect the bladder because the bladder has estrogen receptors, and quite frankly, it should be just lots more of it given out, and it doesn't have any association with breast cancer, and there's been lots of studies about that.
Right, so that actually, it's almost like, would you be killing two birds with one stone, whatever it's called, if there's that condition, isn't it, vaginal atrophy,
vaginal atrophy, and that's what it treats. Yeah.
Right, okay, and so that then helps the bladder as well.
In some people, so I will often get people, especially the more elderly, coming to my clinic, and these ladies saying they're weeing all the time, or they're getting symptoms like urinary tract infections, and actually all they need is to stop caffeine, drink more, use a bit of vaginal estrogen, and they feel an awful lot better. And these are quite conservative measures before you start giving them medicines, which, unless they're necessary, you'd rather avoid, because everything's got side effects.
Okay. So does that, have we kind of covered, so that we're talking really about the muscle down at the bottom, aren't we?
We're talking about the bladder muscle. That's nothing to do with the pelvic floor. We're talking about a pelvic. This is like neurons. This is to do with brain signals and contractility. It's nothing to do with the hammock. So that's so there's detrusor overactivity or overactive bladder symptoms, and then on the other half you've got urinary and stress incontinence, which is your 3 children, jumping on the trampoline and having a leak. So that can be on the one end of the scale, and some people can literally do nothing, lift up something, and they'll have a big leak.
Right.
Again, vicious circles. So they don't want to exercise, they don't want to do anything, because every time they do something, they leak. It just takes away, and then you feel like the anxiety of not wanting to go out and not do anything because you don't want to leak, and nothing can be done. And actually, we can do stuff. So pelvic floor first, but then.
Okay, so that if we take the thing, you've had your child, and you find that you're now leaking. It's never happened to you in your life before, and suddenly, oh my goodness, what happened?
So the first thing I would do is, and actually is one of the trusts that I work in, would be to do supervised pelvic floor exercises. If you've immediately had your child, things take time. Time to go back to normal, and I think it gets worse the more children you have. It does take maybe up to 2 years to get maybe some weight off, to engage your pelvic floors, and it's really, if you're breastfeeding and someone keeps telling you to do a pelvic floor all the time, let's be honest, you're a bit like, I've got enough going on, I've got a nappy to change, it's exhausting. But when you get a bit older, then you can sort of concentrate on doing that. So once you've done your pelvic floor, and your pelvic floor is, some people it will go away, some people they may still leak, and that's when my job comes into, that's when I, what's the word, like work?
Spring into action.
Spring into action, yeah. So that's when I start.
Yeah. So before we get to sort of the sort of grown up, what I would call the sort of grown up stuff, there's obviously lots of things that one can do, because I know that we've had on, we definitely did some trial where we had to help people where they put weight cones or weights.
Yeah, the sort of the weight training, or some people swear by. So the physios, I mean, it's probably best that a women health physio talk, but some people, there's the LV pelvic floor stimulator, and there's the Kegel 8, which I know are popular among. Kegel 8, they like that, and it's got feedback. But even before I would still, if it were me and I had that problem, I would still, if you wanted it, I would go and see a physio and walk up with it and be like, am I using this properly? It's got to be a women's health physio. Someone needs to examine you and see you're doing them properly. Breathing and the engagement. And there's another thing, there's a squeezy app, which is quite good.
A squeezy?
It's developed by some pelvic floor physiotherapists, and it's an app on your phone called the Squeezy app. And it's about reminding you to do your pelvic floors and giving you tips about doing them.
So, but what is it? And I'm sure that all women relate to, as soon as we talk about pelvic floor, you absolutely go like that straight away, don't you? But I can only do one or two, and then I forget I'm meant to be doing it.
Yeah, and then you get distracted. So it's about, I think it's, I mean, I'm as I said, I'm not physio, but it's about how long you do them and repetitive and strength. And it is amazing. Sometimes I saw someone recently and I told her to go, and she had a huge prolapse, and I told her to go up and do a pelvic floor exercise. By the time she got back to me, I was about to operate on her, and I was like, oh, it's not much to operate on here. And she was an elderly woman, and she completely healed herself because she just went, that's what I'm going to do.
So when you say healed, what is the healing actually the development again of the muscles?
Yeah, so the muscle had strengthened and brought it up. I suppose it's like when you have a baby, you have that slight paunch, and then as your muscles come back in and get strength, then that tummy goes back in. I mean, it's easy because you can visualize that. So it's probably the same. Well, it's the same in the vagina.
And then, so presumably, as you get older, which is when the problems happen, then the muscles become weaker, especially if you're not using them and being good with your exercises. Is that's when you start having potentially more of a prolapse, or?
Yeah, so the most people we see is after the menopause. We do see people before, but we try and hold off. So we're going on to when we're going to operate. If we're going to operate, when we operate, we want to do the best operation. Does that make sense? So I want to try. So the first time you operate is the best time you operate. Your results are never going to be as good after your second or third operation. So, and I don't really want to see people back. So I want them to operate and have really good results. So even if you need an operation, say if you had bladder prolapse, and you needed an operation, then I would still say, well, be as strong as you can so that I can remove the prolapse by, fairly simple operation. And then it won't come back, because for the rest of you, it'll all be strong there, and your chance of recurrence is lower.
Right, and so when you have an operation, so the reasons for having an operation is because your womb is it your womb that's prolapsed?
Yeah, so we've moved on to, we've moved on to vaginal prolapse again.
Right, okay.
So if we go back to the bladder, if we get as far as the fact that you're still leaking, then there are things we can do. And we now have like these little injections called Bulkamid, which you put on the where the bladder opens into the urethra, and it's heavy duty filler, basically like facial filler.
Right.
And it basically, if that's my finger, it sort of narrows it so that when you cough, it's smaller. So when you cough, naturally your pelvic floor should pull up, so you'll get a smaller outlet. But if there's still a gap there, you can fill it in slightly by little cushions, and hopefully that will reduce your leaking.
And then, so for example, with filler, as I understand it, filler doesn't last.
So the evidence is about 5 years.
Right.
So it's a newer thing coming back on. We did used to give it, and there's been so much technology come through, and we're sort of possibly slightly gaining on the back of the aesthetics in that it's the same product, but it's very heavy duty, and it should stay there. But the side effects are low. I can do it under local anaesthetic. It's very low risk. It's literally it takes me about 10 minutes, and then you go home.
So is the filler the same as Botox?
No.
And so when you talk about injecting Botox and injecting filler, you're also talking here, as with the face, there's filler and Botox. Yeah. That's the same?
It's completely, Botox and filler are completely separate. Botox puts muscles to sleep. It stops them working.
Right.
So you stop contractility. So that's the same in the face. If you had Botox in your face, it just means your muscles don't work. So
yes, you get that frozen.
Yeah, exactly. So you can't raise eyebrows or whatever. Whereas filler just puffs things out or makes things bigger. And it's called Bulkamid. I'm using the word filler because that's kind of is easy to relate to.
Yeah.
But it just almost fills in the hole. Filler fills in the hole so that you can hopefully leak less. If that makes sense. But it hasn't got quite as good of results as our previous surgery, and it doesn't last as long. but it's got a low side effect profile. And that's what a lot of our, as doctors now, is reducing, not taking too big a risk. It's reducing our risk and assessing our patients properly.
And yes, and I suppose it's not heavy duty surgery, is it?
No, just local anaesthetic, pop it in.
Mm.
Very
Okay. So that's the bladder side of things.
Yeah, and then do you want to talk about so there are other things we can do, like a fat sling and a TV. So before we used to do the mesh tape.
Yeah.
We do the mesh tape at this time. We now harvest, so I can harvest some of the rectus sheath and do exactly the same procedure with your own tissue.
Wow.
It's very effective, but you might have, there's obviously take the risks of major surgery, but it's effective. And there are other operations called a colpo suspension and other bigger operations that we can do for urinary incontinence. What I'm trying to get at is, it's not something women have to live with. There are things we can do. You're fit and healthy.
And I think that's sort of very reassuring for people, isn't it? Is like, you experience this and you're now not suddenly, that's it for the rest of your life. There are lots of things you can do. You don't have to jump straight into having major surgery. You go through, and presumably, is that an NHS sort of pathway that you tried the different interventions as you go along?
So now it's all about, the paternal side of medicine's gone. We sort of advise patients now. So often I'll say to them, well, especially, if you've not finished your family, why would you want major surgery? Or if you're very busy in your job, do you really want 3 months off? It's about weighing the balance up and seeing their point of view and letting them take responsibility. My job is to say, this has got fewer risks, but it might not work. This has got more risk, but it's probably 90% chance to work. Over to you. What do you want me to do? What do you want to talk through it? Some people come in and they're like, this is what I want, and that's fine. Because they're aware of the risks.
And I think, sort of generally speaking, talking about that as surgery, is a much better approach, because, in the old days, and when I say the old days, when I was younger, you were always sort of very much brought up with thinking that the surgeon knows best, and whatever the surgeon does, it's going to work. Now, we do know things don't always work, and I think this allows people to realise that everything has a risk.
Yeah, exactly. And that whole thing of nothing is that they're the surgeon, they know best. Well, actually, it's your body, your choice. If you don't want surgery, I'm like, fine, I don't want to do anything. So, yeah.
Okay, so that's that side. We're moving across now to the other.
The middle compartment. So we're now in the vagina, or the
Okay.
vulva. So that's where you can get bladder prolapse. So you've got I should have a model. I must get one. So the front compartment is the bladder can prolapse. The middle compartment is the uterus can come down, and the back compartment is a posterior wall prolapse, otherwise known as a rectocele. Front is called a cystocele, uterine prolapse. And these, again, pelvic floor exercises, and then we can go down, and we see this more in postmenopausal women, and some women are not suitable to operate on, and it's about making that choice of what's right for that woman. An 80-year-old, often they don't want an operation. I don't blame them. So they might have a pessary put in. Even younger women might say, actually, I'm fine with a pessary. The ring pessaries really help pull everything up. They just put your anatomy into the right place. You can have sex, get on with it. Or if that doesn't work, we've got some other things called Gellhorn pessaries, which are a bit more sort of intrusive, but they keep everything up, and that might be suitable down the surgical route.
And is it because, and the feet, how does one know that one's got this problem? Is it because you suddenly feel that everything's falling down, or?
Yeah, so normally it's a heaviness within the vagina more at the end of the day. They don't tend to cause pain unless they're coming out and causing ulceration. Some people have complete prolapses. Heaviness, feeling just dragging sensation, uncomfortable. With the bladder, one thing that a lot of people complain of is they'll go for a wee, then they'll stand up and they'll have to go back again immediately. So they have a double void, and that's because they empty the front of the bladder. It's prolapsed, hasn't emptied, so they stand up and that hits, and then they go again. And with the rectocele, often you'll find people are usually chronically constipated with a rectocele, or have been in the past, or there's been something else, and often they might have to press a little bit in the vagina to open the bowels or the perineum, which can be quite upsetting for people. And then there's also, because people can feel uncomfortable during intercourse, maybe be put up intercourse.
There's a friend of mine who's a doctor said that she has to quite often go into, especially old ladies, into the homes and push everything up again. So presumably that's what she's...
Yeah, that's prolapse, yeah.
Prolapse. And then with a prolapse operation, do you remove stuff or you just stick it up, sort of?
Often we just stick it up, hook it up, as one could say. So it doesn't say, it sounds quite coarse, but if with a uterine prolapse, you would do what's called a vaginal hysterectomy and remove uterus, because it's basically a vessel, isn't it? If it's not anymore, it's not useful. But if it's coming down and it's impeding on, you can feel it, then we can remove it. But often we'll find actually it's usually bladder prolapse. So we see quite a lot of bladder prolapses, and with a bladder prolapse, all you're really doing is pushing it back in with some good strong stitches which all absorb, removing the bit that's been stretched, and then sewing it up. And I do loads under local anaesthetic now. It takes me about half an hour, 40 minutes. I just like going to a dentist. So that's it's a change in our practice, is that people don't want to go under a big general anaesthetic and or rigmarole. They actually, you go to a dentist, they put it in, ow, and then you don't feel it. And often that's the same. If you're that, you've got to be in the right mindset. But a local anaesthetic, anterior repair, I do quite a few.
And and we're sort of very lightly talking about this, and you just said, well, you just pop in and it only takes me half an hour. And, that's obviously underplaying it in one way. I'm not saying that it takes any longer, but I know that through all the research that we do with, because we do a lot of work, as people will know, on bladder and bowel, and how debilitating these issues are, how people do not go and talk to someone to see what options there are. And your half an hour can change somebody's lifetime.
Yeah, and I think sometimes actually the way I'm speaking about it, maybe I am sort of underplaying it a bit, but... And obviously it's operation, it's surgery, there are risks, but often actually it's fairly straightforward. And if it's it's all about patient selection. A lot of it's about patient selection and the right patient and motivation, etc. And actually people have fairly good results.
But I wasn't meaning that it was a bad thing to underplay it, but I think it's more about trying to say to people, there are things that are available for you, because lots of people read things and go, oh, well, that's for someone else. And you feel like saying, no, that could be an option for you.
Yeah, absolutely.
Just go and talk to an expert and you could be sorted. Because I think sometimes people feel that their issue is completely different from everyone else because they haven't obviously discussed it with anyone, and they just quite often feel it can't be cured. It's happened. I'm never going to get better.
Yeah. No, and I think you're right, actually. This is the way it is. This is the way. And actually, there are things we can do. Even if you're not suitable for an operation, you can put in a pessary or something just to make you more comfortable.
And all of the things that we've spoken about, a lot of them are very much from childbirth, basically. So if we then flip it through to people that have a neurological condition, so for example, they've got MS or something like that, are those operations and the devices that we've spoken about, are they still an option that would work for them?
So the bladder, the MS, which you talk about, the bladder, they tend to have what we call detrusor overactivity. What I talked about earlier with the sort of always needing to go for a weaning, etc. So again, that would be more Botox or some other neuro. So there are other things you can do, such as posterior nerve stimulation, sacral nerve stimulation. there are other things for those patients to try and help.
Mm.
But if you can't, the muscles aren't working, then of course it is worth seeing a pelvic floor physio. See if there's anything you can do.
I think that's the key, isn't it? Just ask and see what could be available, and there's always possibly something that you can do.
Exactly, and I think that's it. And sometimes, occasionally we put these. It's called a drain pipe urethra, and you can imagine there's just nothing in the urethra. You're 90 years old. You're black. The musculature has. You're 90. It's very poor. And women will go from sitting to standing, and often it can be the bladder contracting from sitting to standing, but sometimes it can just be that they go from sitting to standing and there isn't anything stopping it coming out. And actually these ladies can sometimes benefit from a little bit of Bulkamid, just to try and reduce that to them. And it's so debilitating for them, and actually there are things we can do even in more elderly members.
So I don't know if there's anything else that you want to add, but there are a few questions. So I wonder whether we should move on to onto those.
Yeah, go for it.
Oh, I'm really sorry. I've only just answered the open thing, and somebody said, "Could you please increase the sound volume? It's very faint when Georgina speaks, but obviously perfect with Katrina." But which is really is not what you want to be hearing. It's not
sorry about that. Can you hear me?
Yeah, I can. That sounds louder.
Shouting. Okay, sorry.
What could be done for? Oh God, here we go. Some of these wording again. Could be done for cystocele level 2, please.
So cystocele grade 2. So the initial, our management would be pelvic floor exercises initially to see if you can remove the cystocele, make it strong. And if it doesn't work, then the options are a ring pessary, which if that stays in and it fits, and especially they're better if you've got a stronger pelvic floor because it stays in, or you could do an anterior wall repair on that, anterior vaginal repair.
Thank you.
That's the operation I talked about earlier.
Yeah. I suffer from urgency incontinence and completely stopped caffeine, but still suffered a lot. I do take Physicare, and have a mild prolapse. However, I have recently started vaginal estrogen, and I found this has helped significantly. That's good.
There you go.
Yay! Not completely resolved, but much better. So does it look to be related to perimenopausal also?
Yeah, most likely. Yeah. So if it's significantly better, that's brilliant. So if it's related to slight lacking in estrogen, which is what I talked about earlier, simple measure.
It's really nice to hear when something's worked, isn't it? You hear about
feedback.
Yeah, exactly. Right. I'm not sure I've understood. Is regular sexual activity good or bad for the pelvic floor?
Probably good. I don't think it makes much difference, but I think regular sexual activity doesn't make any difference, really. Although if you're using your pelvic floor during sexual activity, that's a good thing. That makes sense. So, if you're pulling up your pelvic floor during intercourse, marvellous.
And actually going back to thinking about your weightlifter, I think that's something, isn't it, with how people do so much damage is because they're not using the correct, basically your core muscles to do what you're meant to be doing. So when you're lifting weights, you shouldn't be using your pelvic floor, you should be using your tummy, I suppose, core.
Engage and pull up. And it's about doing all these things, hands up. My husband is, if I lift something, my husband's like, that sort of, and I, straight back, bend your knees, and I'm, and actually he's right. It's about doing it properly.
Yeah, definitely. And I've found when I go to the gym to, try and lift my weights and all those things, you suddenly realise you can lift far more than you thought you would if you do it properly. And you don't use your arms, you use your legs or whatever it is you're meant to be using. It's about doing things properly, isn't it?
It's funny how the world's changed, hasn't it? Quite a lot. People are much more sort of involved in all this and think about it. Whereas I think before nobody really thought about it. They just did what they did and didn't think about the harm that would cause their body or whatever.
Well, I suppose that's what, so we're evolving, and I hope, you know, this is an example of good education, of learning something and how to improve.
Absolutely.
Right, apparently our sound has improved, so hopefully people did hear properly. Perfect on the sound. I have found, somebody says, I have found managing my tea drinking has helped my MS bladder loo frequency.
Oh, good. I'm glad.
So that
yeah, MS patients, you know, that it's hard, really, it's so hard, but that's good.
I've been diagnosed with rectocele.
Rectocele, yeah.
Right. How much benefit are pelvic floor exercises?
A lot. So it's all about sort of, so with a rectocele and a cystocele, reduce weight, constipation. Constipation is the worst. It strains on that pelvic floor. Flax seeds, simple measures, increasing your roughage. And I swear by flax seeds. You're still straining. I'll find sometimes I'm thinking, oh, I don't want to take medicine, but then they're still straining. So you're sort of, you need to kind of take the medicine to stop the straining, because actually constipation isn't good. And if you, once you've improved your constipation and done your pelvic floor, then it's a fair, you know, then we can operate with what we call a posterior vaginal repair, and we can do a perineuriopathy where we just sort of pull it up a wee bit.
Right. And also you don't want to get piles, because that's the way you get piles, isn't it, Barry?
Unpleasant. Yeah.
Not good. I've been diagnosed with a semi-prolapse. What does that mean, and do I need surgery?
So I don't have semi-prolapse in my, I should imagine it means sort of a mild or moderate prolapse.
Right.
I don't really, semi isn't just not some sort of language we use, but hopefully not. Hopefully pelvic floor exercises will be enough. If it's not, then they can consider surgery. A little point is often a lot of trusts won't operate with a BMI less than 30, more than 35. So weight's also really important for all these surgeries, especially something like stress incontinence, where actually a small reduction in your weight can give a huge amount of relief to urinary leakage, and that we know that.
Right. And is that also because that if you had the if you were severely overweight, well, I'm not even sure a BMI of 35 is necessarily severely overweight, but obviously carrying more weight than is, that means the outcome of the operation is not what would be expected.
Yeah, it'll just come back. It'll just
Right.
come back because you haven't taken away the trigger factors. Weight, similarly with constipation, it just won't work. If you're smoking 40 a day and you've got a chronic cough, and I operate on you, then if you're still coughing, you're still putting that pressure on the pelvic floor. It's going to return because you haven't taken the preventative measures first.
And I think that's also with lots of things, isn't it? It isn't always the surgeon's job. We as individuals have to take responsibility for making sure that we're best prepared with our bodies before we have surgery.
Yeah, absolutely.
I don't know if this is an obvious sort of question or we've answered it for this person. How much better can exercises make your pelvic floor?
A lot. Some people it might be too far gone. Okay, that's fact. You know, if you've got a prolapse which is huge coming out, a pelvic floor exercises isn't going to make it a lot better. What I would do is if I operate, then it will prevent it recurring if you've got strong pelvic floor exercises. Our recurrence rate is really quite high, and it's not about the surgical technique. It's about the fact that if you haven't taken away the factors that caused it.
Right. Okay, and I've just got one more here. I think we'll stop here. I was told I had relatively strong pelvic floor muscles, but still that cystocele 2 not improving and preventing me to go out much as I have many accidents every day and nights. I'm only in my mid-50s. I don't drink caffeinated drinks, drink only water, but very much in excess as medications get me so dried out. No constipation as I eat lots of fibre, but obese, yet again due to medication, which is obviously one of the problems. Where can I find good explanation of pelvic floor exercises, and how much should I do?
So the question is, has she seen someone to do supervised pelvic floor exercises, like a proper women's health physio? And they're probably the best people to direct you. So I work very closely with women's health physio. And what happens is if they see a patient and they think we've done what we've done and she's got good pelvic floor, but she's still suffering from prolapse, then they just directly refer to me, and it's seamless. Thank you. Sounds good. Let's operate. That's sort of how we work, and that's how we should be working now.
Yes, and once again, we've seen that in so many things, isn't it? It's the combined, it's each sort of disciplines talking to each other really works.
Exactly, and talking normally, saying, this works, this lady, she wants to run and she wants to exercise, but she's been limited by this prolapse. She's done a pelvic floors, Georgie. I think she'd benefit for an operation. And then I'll turn around and say, she got any other risk factors? She's constipated. They'll be like, no, we've sorted it all. Everything's sorted. I think it's time for an operation. Okay. I talk her through that bit.
Brill.
Okay.
Right then, I'm going to keep doing my pelvic floor. Unfortunately, you can't say I've done 100 in my lifetime, that's it, all sorted. You have to carry on, don't you?
The Squeezy app, people swear by the Squeezy app, so
yes,
not everyone download it.
I've never heard of that, but I'm going to have to go and have an investigate.
Yeah, all about the pelvic floor. All right.
Pelvic floor. Thank you so much. Really nice to see you again. Thank you, everybody, for the questions. Bye.